and let the people catch up, okay? 1, 2, 3. Why don't you move over? That way you can ask questions much quieter. Everybody can hear me. All right, this is the smallest class, I guess. Look at that. Now 5 people. I had to pay Dr. Mayer to come. I knew that there will be a low attendance, so I had to pay him to come and listen to me. Well, he goes and studies after this, you know. That's right. Absolutely. Okay, what we're going to talk about is hypersensitivity. Well, it's one of those conditions in which the immune system does a damage to the host. You could call it immunopathology. So you'll probably get this topic in pathology as well. That will reinforce some of it. One can define hypersensitivity as a damage to host mediated by pre-existing immunity. Okay? What it really means is there are components or products of the immune system, or products of immune response, coexist there together with antigen. Really, that's what really the condition in which there will be damage. Booster to to vaccines. I asked you the other day how many of you had reactions. Well, there are more severe reactions at booster than there are at the primary first shot, because the product of the immune system is already there. Okay? So that is the definition. Now, I'm not saying that you cannot get hypersensitivity after just one shot of antigen. Depends on how much the antigen is. You saw in your yesterday's POPs that there was danger of serum sickness after passive immunization, because that first inoculation of that foreign protein was in a large amount, and the antibody and antigen existed at the same time. So they could interact, right? And cause serum sickness. And I'll go over serum sickness once again when we come to that type of hypersensitivity. So that's the general definition of hypersensitivity. It's a very important phenomenon because a lot of infectious agents, when Dr. Fox comes and talks about the immunopathogenesis or pathogenesis of infections, he'll emphasize that it is the immune system that causes the damage to the host during some infections, and not the bacteria themselves cause the damage. What is the impact? Well, just let's look at a little bit background of that before we go into different types of hypersensitivity. Allergic rhinitis, this is an older figure, and it has increased, okay? And probably is underestimated because not everybody with rhinitis goes to the physician, okay? So about 32 million chronic sinusitis, about 5-6 million with contact dermatitis, about 12 million with skin rashes, and asthma, 10 to 12 million with asthma. And these are the visitation. Anaphylaxis, a smaller number, but there are a significant number that come down with anaphylaxis and have to either go to the emergency room or to the nearest physician, their family physician. So, bottom line is, if you become a clinical immunologist, you're not going to be short of patients. Okay? Allergists or immunologists. So think about it. Yes, you had a question. Rhinitis, itis means inflammation or, inflammation, and rhinus, the nose part, so inflammation of the nasal passage, okay? All right. And I feel the hypersensitivity has been sort of historically divided into 4 major categories, and they have just been called type 1, type 2, type 3, and type 4. But there are other names, synonyms for that. For example, type 1 is also known as anaphylactic or immediate hypersensitivity. Anaphylactic or immediate hypersensitivity. The type 2 is also known as cytotoxic, and type 3 is also known as immune complex, and the type 4 as delayed hypersensitivity or cell-mediated hypersensitivity. You were introduced to the concept of humoral and cell-mediated immune responses by both Dr. Mayer, and then there was a good discussion of it in the POPS exercise. The second names just sort of depict or signify or point to the mechanism by which the damages occur or the time frame from exposure to the antigen to the reaction that is consequence of that hypersensitivity. Okay? We will start with type 1. Type 1 is common allergy, and this is a very small attending class, so I will still be willing to bet that I'll find one or two people who have got hay fever or they get dermatitis urticaria or, certainly the flu, the summer season hay fever. How many? Let's see. Come on now. Yeah, I won't lose that bet. So that just tells you that a good proportion of us do suffer from type 1 hypersensitivity. And most of you, you are here, therefore none of the reactions have been really fatal or serious. But it can lead to fatal reactions, and that I'll give you just one example. But every year there are reports of that kind of reaction. Well, the common allergy that can just sort of be detected while you're walking the mall or walking the street, or, there are people who are making silly faces. They are not really making faces at you. They just can't help it. There it is, another one like that, or another one like that. Or, so those are the funny parts of it, or you can say that the minor symptoms. But there are cases like that. Every year you will see one or two cases being reported or being observed. The diners, they go to a restaurant, they order something, and they do not know what the ingredients are, and some of them may be allergic to peanuts, some of them may be allergic to walnut, some of them may be allergic to other components, and at times they do end up with serious anaphylactic reactions. Not always, hopefully not always fatal, but they are serious enough to be fatal. Okay. Rhinorrhea is one of the symptoms. Running nose, that's the other name. That affects nasopharynx, nasal polyps, very painful. Tonsillitis. In the old days, they took out the tonsils because they thought it was infected tonsils. The skin, generalized urticaria, rashes or hives, one really calls it in the common terminology. Eczema, very severe condition here, and that sort of condition may lead to secondary infections and problems with the skin. Conjunctivitis, runny eyes and redness, inflammation of the conjunctiva. Asthma, very typical truncated chest resulting from chronic asthmatic condition. Okay, I couldn't find any suitable pictures for those. Okay, so you'll just have to live with words there. So they are vomiting, diarrhea, and GI problems as a consequence of allergic reaction. One says allergic reaction. I'm using that term, often it is used, but allergic condition is sometimes used in a more broad way for other hypersensitivities as well. But by and large, the more specific use of allergy is type 1 hypersensitivity. Okay, what is the mechanism? Well, the mechanism is no different, and you'll see that I'm reviewing the whole sort of immune response as I go along with different hypersensitivities. Well, we are not born with allergic conditions, but we sort of inhale allergens, and the allergens are taken up by antigen processing cells. They are degraded. They associate with class 2 MHC molecules. They are transported to the membrane, and there are cells that can recognize those peptides from these allergens, T cells that can recognize those. And in this case, the T cells that are reactive, that are responsible for allergic reactions, are the Th2, because it's an antibody-mediated immune response. And for some reason, there are multiple factors. One factor is the characteristic of that antigenic peptide. The other one is the MHC molecule that they associate with, and the third one is, of course, the nature of T cells, and those three things interacting together produce interleukins of different types, but they're disproportionate, leaning towards more IL-4 and IL-5 and IL-13. Okay? And that kind of, those cytokines, those interleukins, tend to activate B cells, of course in association with the antigen combining with them, and the B cells also have on their surface receptors, or the B cell receptor or immunoglobulin, IgE receptor for the same antigen. That leads to development of these B cells into plasma cells that preferentially secrete IgE, immunoglobulin E. Okay? And Dr. Mayer told you the significance of immunoglobulin E. That the major contribution to, at least in our Western society, is make us suffer. Hypersensitivity. Obviously, it did not evolve to make us suffer. It evolved, as Dr. Mayer mentioned, that IgE has got a major role in helminthic infection, worm infections. But we don't have that many worms. They're more in South Carolina than other places, or generally in the South. But these IgE molecules have got a very characteristic feature again that Dr. Mayer pointed to. They have got a very, very high affinity for a receptor on mast cells. IgE receptor is sometimes also referred to Fc epsilon. Fc epsilon. Or CD23 you'll find some places as well. There are a couple of there's several different affinity receptors. I'm not going to go into that. But IgE has got a predilection for combining without any antigen reaction. Remember, most of the immunoglobulins, IgG particular, well, IgG is the only other one that binds to Fc receptor, but IgG requires combination with antigen before it can combine with the receptor. IgE is unique in that respect that it does not have to combine with the antigen to bind to its receptor on mast cells. As a matter of fact, you know that IgE is the lowest probably concentration of serum immunoglobulins among normal individuals, non-allergic normal individuals. The reason is that IgE has got a very, very short half-life unless it binds to its receptor. It's only 2.5 days or something like that, okay? But when it binds to that, it's 10 times longer. It can persist 10 times longer. Okay, half-life, it becomes very stable. Okay, so, and this binding is referred to as sensitization of mast cells. Mast cells have been sensitized with IgE. And, of course, the pollen has not gone away. We're still inhaling pollen, or they're getting into eyes or nasal passages. And as they get in, they are going to combine with this specific receptor on mast cells, and they are going to cross-link this immunoglobulin. That cross-linking is a very significant event in terms of physiology of these mast cells. What that cross-linking of immunoglobulin does is sends a signal into the cell, into the mast cells, to undergo certain internal metabolic pathways. Most important among them is really increase in intracellular cytoplasmic calcium molecules. But the consequence of that signaling is release of granules that have preformed pharmacologically active molecules. And the degranulation releases those molecules into the circulation, into the local environment in the body. And these include histamine, tryptase, kinageninase, and eosinophil chemotactic factor of anaphylaxis, ECFA. And you all know what these molecules do. Histamine is the major culprit, actually. It causes vasodilatation, increased secretion of mucus and other secretions. That's why we have runny nose. That's why we have congestion of the chest. That's why we have runny eyes. Okay, tryptase, of course, a proteolytic enzyme, kinageninase, activates kinin system and causes swelling of the local swelling. How many of you have been bitten by a fire ant and come down with an immediately swollen foot? Okay, that's kininogen and becoming kinin. Okay, and ECFA, eosinophil chemotactic factor, attracts eosinophils, and eosinophils also have the IgE receptor. They also have receptor for histamine, and they are activated, and they have inflammatory granules as well, very similar to basophils. So they increase the local inflammation even further. They amplify. Okay, those are pre-sensitized molecules, but then that interaction with the antigen, that activation of mast cells, also delivers a signal to synthesize certain newer molecules. And among them most significant are leukotrienes B4, C4, and D4. Chemotactic activity. There is these are very much similar in their action, in their physiologic action as histamine, but they are 1,000 times more potent. So for these molecules, it takes a little bit of time, 10 to 12 hours, okay? So that's why there is some delayed reaction as well after exposure to these allergens. Prostaglandins, they are, some of them are chemotactic, some of them cause swelling and pain. PA, platelet activation factor, that is going to activate platelets, and they have heparin and histamine as well. Okay, they have got other pharmacologically active substances. That's why vasodilatation and erythema and erythematous reaction due to vasodilation and of course, the cardiac problems as well, shock. So histamine, as well as leukotriene, as well as platelet activation factor, platelet products lead to shock. Okay, and that's why in an anaphylactic reaction, the ultimate is shock and death. Okay, so that is the general scheme of events that takes place during hypersensitivity. Understanding of these events also has led us to development of various drugs and that are extremely effective. Extremely. I mean, allergy is very, very much manageable state. I take about 3 or different kinds of anti-allergic, or 3-4 kinds of every day. Otherwise, without that, I'll probably be wheezing and, I'm asthmatic, actually allergic asthma. And a lot of people are that way. Okay, preformed mediators I've already explained to you are histamine, that causes bronchoconstriction, mucus secretion, vascular permeability, and vasodilatation. And from your physiology, from your histology and gross anatomy, you know that why they cause bronchial tubes to constrict, whereas their muscular, the cell arrangement is somewhat different. So one is, in one case there's constriction, the other case dilatation. Okay, tryptase proteolysis. So locally there's a damage of the proteins in cells as well as extracellular matrix proteins damage. Kininogen converts to kinin, causes vascular permeability, and again vasodilation and edema. ECFA I already described. In addition to attracting basophils and eosinophils, it should be eosinophils actually. Eosinophil chemotactic factor of anaphylaxis. So I'll correct that myself. And they also attract some neutrophils. They are also inflammatory cells. So that the whole, the local environment is getting inflamed. And it is very, very quick because all of these are preformed mediators. That's why after ant bite or insect bite or by introducing subdermally, dermally by scratching some allergen, you get the hives right away. Okay. Newly formed mediators, I already described before, attracts neutrophils and basophils to the site. Leukotriene C4 and D4, same as histamine, but more potent. I already described that. So did I describe the prostaglandin D2 and PAF? And there's a table in your handout that this summarizes all those. Okay, so that is how the type 1 hypersensitivity occurs. Any questions so far? So while you're thinking, Okay. The prostaglandin is more sort of, pain, molecule. Histamine, it's a sort of a scratching, itchiness. Okay. Chemotactic factor, but also attracts neutrophils. Okay? That's what the name actually signifies, eosinophil chemotactic factor of anaphylaxis. And, okay? All right. You will find that there is a little bit of dichotomy with what I say now and then what I will describe later on, the chain of events, intracellular events. Cyclic AMP levels, determine a lot of reactivity of the activity of cells, we know that the cyclic AMP rising causes secretions to increase, and therefore nasal secretions and so forth are, consequence of increased cyclic AMP. In the whole event that after the cross-linking of those IgE molecules, the very first thing that happens is a transient cyclic AMP increase. However, it has been noted that if one increases the cyclic AMP in a sustained level, intracellular cyclic AMP in a sustained level, that has got a quite opposite pharmacologic effect. In other words, it can relieve the symptoms of allergy. It can relax the smooth muscle cells. Relaxation, and it decreases the secretory function as well. And as a result, the drugs that have the ability of sustaining increased cyclic AMP are used in the treatment, and epinephrine, isoproterenol are beta agonists, and they increase the cyclic AMP level. Alpha blockers, phenoxybenzamine, phosphodiesterase inhibitors, theophylline, these are used as anti-anaphylactic agents for anti-allergy agents. Epinephrine, isoproterenol. Isoproterenol is the inhalant, often used. Okay, so these are the substances that are. On the contrary, if one can, alpha agonists that are alpha agonists or blockers of the beta receptor, they tend to decrease cyclic AMP, increase cyclic GMP, and these are drugs that are going to worsen the symptoms. Okay? That's why the people who are on beta blockers, beta blockers often wheeze. One of the side effects of people on chronic beta blocker treatment have wheezing symptoms. Okay, how does one diagnose? The diagnosis is very much sort of biological, really, not a laboratory diagnosis. It's reactivity of the skin to different allergens. Here there is actually, one has used dilutions of histamine that is used as a control, but those of you who are allergic to substances and have been to the allergist know what it is to undergo the diagnostic test. Well, they start with the arm with the different allergens, and then the other arm, and then they run out of space, and they go to the back, skin on the back, and you'll see here's an individual who is, that is the actually diagnosis in the individual itself. One can use IgE levels as an indicator of hypersensitivity. Most of the people who have got severe type 1 allergy, type 1 hypersensitivity or allergy, they have increased levels of IgE. Mild symptoms you may not find very much increased, but then as they become eczematous and asthmatic, the IgE levels are way, way up there. However, the IgE increase is not only confined to hypersensitivity state. It is also increased in helminthic infection. Of course, it is natural to do that, for the body to do that, because that's the immunoglobulin that has evolved to fight helminthic infections. There are immunodeficiencies that we will talk about again, particularly hyper-IgE syndrome and Wiskott-Aldrich syndrome, in which the IgE levels are raised. And then there is increased IgE levels in bronchopulmonary aspergillosis. Actually is an allergic condition where more than one type of hypersensitivity plays a role. Then IgE myelomas, one would expect IgE levels to be way, way up. As a matter of fact, IgE was first discovered because of somebody having IgE myelomas. Before that, there was no clue as to what was the cause of type 1 hypersensitivity. I'll tell you, in the 60s, mid to late 60s, I went to my family physician in England, and he sort of, thought that it was a chronic sinus infection and anything, or cold that I couldn't get rid of. Allergies were not identified that readily at that time. Okay, so IgE myelomas also would have increased IgE levels. How does one measure those? I think you have gone through that, the ELISA method, competitive ELISA, that Dr. Mayer described, and that's the easier. But having said that, very few allergists sort of go through measurement of IgE. Very rare conditions they will do that. Otherwise, most common is just the skin test. Those of you who went there were okay. All right, treatments. There are several levels of treatments, symptomatic treatments we all can take. Go to the drugstore and take over-the-counter anti-allergy or the antihistamines. Okay? And they block the histamine receptor. They are not a treatment, actually. They are relievers of symptoms. Everything is there. The histamine has been released. The reaction has occurred. Everything is there. We are just blocking the action of one of the components of the type 1 hypersensitivity or allergy. That's not really a treatment. Like the antihistamines will not affect the delayed reaction because leukotrienes have got a different receptor, so there are anti-leukotriene blockers as well. Okay? Then there are bronchodilators, beta agonists, inhalants, that we use if we have got allergic asthmatic condition. We use corticosteroid or cortisone, different analogs, and that are incorporated sometimes in these inhalants, sometimes nasal spray. So those are also to relieve inflammation. Then there is a little bit earlier level of treatment that is to prevent intracellular calcium increase. I told you that the cross-linking, the very first step is necessary for the reaction to start is cross-linking. And that cross-linking sends a signal and there is an increase in cytosolic calcium. And one can inhibit that by cromolyn sodium is one of the, sodium chromoglycate is the compound, and cromolyn sodium is the, I think, another name, and that inhibits the calcium increase. Also stabilizes the membrane, and degranulation is slower or prevents degranulation. Phosphodiesterase theophylline has also similar mode of action in addition to increasing the intracellular cyclic AMP. Then there is the next level of treatment at an earlier event, and that is hyposensitization, or commonly known as allergy shots. Okay? Hyposensitization is based on the principle, perhaps it's somewhat like low-dose tolerance. Okay? Any of you had allergy shots? Anybody? Yes? Okay. The physician asks you to come, injects a small amount of the same allergens or a cocktail if you're allergic to a lot of things, allergen under the skin, asks you to wait there so that there is no untoward or serious anaphylactic reaction, and then you keep on coming back, and it's a series of shots, not just one shot. And it seems to work, okay? And that is referred to as, in the old days, you'll see, or older notes and books, you'll see desensitization, but the more appropriate name is hyposensitization. And then there is another treatment that also acts prior to degranulation, but after the production of antibody. And that is treatment with an anti-IgE Fc antibody. And that was approved by the FDA only about 2-3 years ago, 2.5, 3 years ago. I'll go through the principle of that too in a minute. Okay, how hyposensitization, here is a case of hyposensitization prior to and after a boy allergic to wasp or yellow jacket or bee bites, bee venom. And how it works, what has been observed that as one receives allergy shots, there's a drop in IgE levels in these patients, and also an increase in IgG levels. Now you can visualize that if you have got lots of IgG against pollen and very little IgE, the antibody will combine. The pollen will react with IgG and get cleared away from the circulation before it has a chance to cross-link the IgE that is on the mast cells, on basophils or mast cells. Also, since the IgE levels have decreased, the sensitization of mast cells is not so severe. So the reduction in IgE, increase in IgG, ends up in relief from allergies. There are lots of publication and lots of experimental data also to suggest that there's an increase in immunoregulatory cells that can downregulate the IgE responses. And that's probably why the IgE levels are decreasing too. There is certainly a shift from lower level of IL-4 and lower level of IL-13 in these patients. Okay? So everything sort of tilts the balance away from producing IgE and towards other immune responses. They also have an increase in Th1 responses to these allergens. Interferon gamma is increased in response to the allergen in these patients. So immunotherapy works in those different ways. Okay. Anti-IgE treatment. Remember I told you earlier that if you have anti-IgE, if you cross-link the IgE on the mast cells, you are going to get degranulation. And when this, I heard the sort of report, I didn't look at the paper first. When I had the report that anti-IgE being used as a treatment, I said, well, that doesn't make sense because anti-IgE is going to cross-link, okay? And it does happen, provided the antibody is of a particular type of antibody specificity. This antibody has the specificity for this part of the IgE molecule, the part that combines with the receptor on mast cells. So what it does is really, well, in the case of this case scenario, there's a cross-linking and release. But in this case, the anti-IgE antibody reacts with the Fc part of the IgE molecule, blocks it, and now this is IgG antibodies. These are IgG antibodies, and they cannot bind to IgE receptor on mast cells. And ultimately, they are going to be cleared from circulation because they have become immune complexes, will be recognized by neutrophils, macrophages, phagocytic cells. They're going to be recognized, degraded, and the IgE levels will be the IgE levels will be reduced as well. And it has been approved for, I think, food allergies or asthma. The FDA has got this idea that each drug has got to be approved for a particular condition. However, there is no reason why it cannot be used in any type 1 hypersensitivity where you need to block the IgE. So that is the basis for treatment. Okay, that's a spelling mistake. That's a typo. It's a type 2 hypersensitivity we'll talk about. Before that, I'll stop for a few moments and let you reflect and also ask any questions. Yes. Mm-hmm. I'm going to come to that. That is actually not type 1 hypersensitivity. Okay, so I'll come to that in a little while. Any other, yes, question there? Again, that is not type 1 hypersensitivity. I'll come to that too. The question was the poison ivy reaction. Okay, how does that work? Yes. Why do some kids, and a lot of kids, they do grow out of, particularly, I mean, I have seen, with my own children and other children, they get reaction to apples and fruits and so forth. Obviously, the more exposure, and there is a school of thought, actually. There was a study published for several thousand patients from Italy, I think, that they took people who are continuously exposed to dirty, so-called, quote, dirty environment. lots of immunogens, lots of bacteria, lots of things that, come from not so hygienic environment. Actually, they took urban versus farm workers, those who were more exposed to cow manure and, all sorts of things. I'm not advocating to smear cow manure on the umbilical cord, as you saw. No, but they found that there was the type 1 hypersensitivity in that population was lower than the other. What it is continuous exposure can lead to somewhat like hypersensitization. That's the explanation I will give. As they are continuously stimulated, of course, also get other infections, interferon gamma levels, Th1 cells responses go up. Okay, so the balance tilts towards Th1 response, less of IL-13, less of IL-4 production. Okay, yes. Yeah, and you all heard that can you develop tolerance, by exposure to hypersensitization? Perhaps works that way. I did say that it is analogous to low dose tolerance, continuously giving you again and again, the same allergen in certain doses that are tolerogenic rather than immunogenic. So you're increasing the regulatory cells, bring down the responsive cells, reduce the also, one of the things that, when you work in the lab, you realize that those things. And lower doses of antigen, same antigen. If you're using any antigen, take any antigen as an example, lower doses tend to stimulate more cell-mediated immunity. For a threshold humoral immune response, antibody response, you need higher doses. So Th1 response is favored by lower doses than Th2 response. Okay? Any other questions? I don't know. I have not seen, I don't see patients, so I don't know what the experience is. But hypersensitization is definitely used. It is more effective. Hypersensitization is more effective for allergens that create systemic response. Okay, systemic. Bite is there and anaphylaxis is anaphylactic reaction. The things that go into circulation a little bit more. And protein, these simpler soluble protein antigens are much more, much easier to treat by hypersensitization, perhaps because it goes through the circulation and mechanism is different. But the venoms, hypersensitization with bee venoms and insect venoms is much more effective than, for example, pollens, although pollens, the hypersensitization is effective as well. But food allergies are very, very difficult to treat by hypersensitization. Hypersensitization is almost not effective against those. Okay, so hypersensitization doesn't work for everything. Okay? Any other questions? All right, we'll move on to type 2 hypersensitivity. That's a lot simpler and shorter for time I'll take. And here, again, the mechanism is the same. An antigen or allergen comes along, processed by APC. Again, the same thing. You'll get bored of this. Okay, Th2 response, IL-4. Now, IL-4 is necessary for other antibodies as well. Remember, Dr. Mayer and probably Dr. McCallop mentioned that IL-4 induces IgA response as well. Okay? But it's the levels and it's the combination of cytokines. And I've got only 2 or 3 cytokines. In the body, there are many cytokines, and it is being realized that it's the proportion of different cytokines that determine what kind of a class or subclass of immunoglobulin you're going to produce and what kind of response you're going to produce, Th1 response or Th2 response. Anyway, to cut it short, that they are going to stimulate the B cells that are reacting, of course, also with the antigen. One signal is by the antigen, and the other signal is by the cytokines and other interactions as well. And they differentiate into plasma cells. They are going to produce IgM or IgG antibodies. Okay? And these IgM and IgG antibodies are going to bind to cells and tissues in the body. Now, what kind of antibodies would they be? They will be autoantibodies most of the time. Most of the time, they will be autoantibodies. So the best example of type 2 hypersensitivity are autoimmune diseases in which antibody is the effector mechanism of damage. Okay, Hashimoto's thyroiditis, hemolytic anemia, pemphigus, we talked about, where anti is in the skin, the desmosomes or pemphigoid, where there's basement membrane antibodies. Okay, so you're going to have that combination. And then, once they have bound there, what are they going to do? You all know that. Dr. Mayer told you about classical pathway of complement activation. Complement will combine, and the rest of the cascade will go on, and these cells are going to damage. The products of these complement activation are going to attract neutrophils. Not only that, but neutrophils also have a receptor for Fc, and they're going to combine, and here it shows macrophages, but neutrophils would be just the same. Okay, they're going to cause damage. Here is the neutrophil as well. And when these cells, they bind to whole tissue, they're not going to gobble up the whole tissue. They're just too small. But they still want to, and that is referred to as frustrated phagocytosis. Okay? And in the process of that frustrated phagocytosis, they spill all the granules, and those granules have got toxic substances. Okay? And that is going to cause damage to the cell. So those are the mechanisms of damage. Of course, the complement products and the other products are going to activate platelets, and they are going to release their products, vasodilation, and leading to erythematous reaction. Okay, so there will be a lot of inflammatory reaction going on, and that is what happens in autoimmune diseases where there's antibodies. Now, it is not only autoimmune diseases that there is hypersensitivity, type 2 hypersensitivity. You can also have type 2 hypersensitivity to external antigens. Those antigens that tend to either stimulate antibodies that are cross-reactive, or, even worse, those small molecules, certain small molecules have got affinity, the ability to combine with proteins, self-proteins on the tissues and cells. And I'll give you the examples of that. This is just an example of course, in this case, it's a pemphigus skin that you saw before. Okay, that's a typical example of type 1 hypersensitivity. Okay. But there are drugs and various other molecules that can combine with different cells, cellular proteins, and they become part of that cell. Of course, those are also molecules that are haptenic. They combine with the proteins that are external as well as internal proteins, and stimulate antibody response. So now you have got the same molecule against which there's antibody has been produced, and same molecule is on the cell surface. Well, cell surface has become a target for those antibodies. And here it is, the drugs, there are certain drugs that can absorb to red cells, and then the antibodies are stimulated against these drugs, and they will combine with the red cells that have those antigens, that drug molecule as part of the membrane, and complement will get activated, and those cells are going to be lysed. And penicillin was one of the molecules actually that can cause chronic treatment with penicillin. In some individuals will stimulate antibodies against penicillin. Penicillin also, or its byproducts, can combine with the red cells, sensitized red cells, and there will be drug-induced hemolytic anemia. I'm sorry? Penicillin is one of the penicillin. In your handout, there are examples of some drugs that combine with quinine derivatives and other types of cells, and then there are other cells that are called idiopathic or drug-induced thrombocytopenia. Okay, platelets they can reduce. Okay, penicillin, chloropromazine, phenacetin, that's a sort of analgesic, has the ability to bind to red cells and stimulate antibodies against itself as a hapten, and cause anemia. Granulocyte quinidine, aminopyridine is the examples, and there are many others. I don't hold you responsible for memorizing the whole list. Just remember that there are drugs that will stimulate antibodies of IgG, complement-fixing antibodies, that will cause those reactions. Okay? And in the case of platelets, sulfonamides and thiazides, sulfur compounds, they tend to bind to platelets, okay, and cause thrombocytopenia. Okay, so how can one detect these? Of course, if it's a drug-induced exogenous antigen, you've got to detect antibodies against those, and you can use ELISA-type reactions for detecting those antibodies against those haptens or those drugs. That would be laboratory diagnosis. The history of the patient will tell you that, well, okay, they had none of those problems, if it is penicillin or those drugs that bind to red cells, no anemia, and then they came down with, destruction of red cells after that. That will indicate to that cause of anemia. And it can be confirmed by detecting antibodies in the lab. In the autoimmune disease, if it's autoimmune condition, one can use immunofluorescence test on a biopsy or indirectly on another tissue specimen. And the antibodies, since these antibodies are going to be against the components of that particular tissue, it will be distributed, the antigen will be distributed evenly throughout on the cells, as you can see here, and the fluorescent pattern will be very much linear and smooth, suggesting that, it's a part of that red cell. You will not see the pattern like this that you will see in some other conditions. And this is the example I showed you earlier in the case of Goodpasture syndrome. Goodpasture syndrome is one of the conditions where the antibodies are against the basement membrane. Okay, I should not get carried away and continue. I'll give you your break, and we'll continue afterwards.